What we'll probably just start to do is take some questions at the end. So if there's something really pertinent, write it down so we make sure we address it, or if it's something you want to talk to us personally afterwards, please feel free to come up to us and we can talk about it. So we're going to talk about cardiovascular health. And this is a huge topic, and kind of going through this, I'm like, how can I pare this down into something that's kind of a manageable? So I'm going to there's some areas I might just kind of skip over, but there's areas I think we really need to focus on a little bit more. So we're going to do, if you don't want to raise your hand, you can. So who knows someone who's had heart disease? All right, okay. Who knows someone who has high blood pressure? Okay. What about having a heart attack? Stroke? Diabetes? Ever heard the term metabolic syndrome? All right, so all these kind of encompass in cardiovascular health. So it impacts every single one of us, personally, our families and stuff.
We just got some feedback about the sound. It's a little bit difficult to hear.
Oh. Are we good here? All right. Yeah, just
let us know if you can hear, and if you can't, can you raise your hand again?
Yeah, or pat the top of your head. So it impacts all of us, whether it be personally, whether it be a family member, whether it be a coworker or a friend and stuff. So I think we all need to look at it that it's global. And some of the statistics are actually pretty, where's my forward arrow? Are pretty, kind of interesting to note about. So this is kind of our agenda for tonight. We're going to talk about some risks, talking about functional medicine approach, talking about what plaque formation is, and then cholesterol, and then things that we can do, as a preventative measure. And there's some really key points I think we need to kind of address that maybe have been skipped over in the past. I know, someone goes, you have high blood pressure, metabolic syndrome. Just go and exercise and lose weight. Well, that's a pretty big thing to tell someone to do, especially when they're like, well, where do I start? What do I do? What's the best option for me? Still? All right. So some of our statistics and stuff, 50% of all women who have had a heart attack have a normal cholesterol panel. And this is the typical cholesterol panels that you see when you go to your doctor and they go, here's your cholesterol panel. See, it's normal. You have no risk. 50% of all women who have a heart attack have that panel that's normal. So it doesn't really tell us very much information. 62% of men and 46% of women whose first symptoms of cardiovascular disease is a heart attack. So their first symptom is a heart attack. That's pretty scary. So you're going into the hospital and you're getting we call it the $1 million workup. You're getting all the tests. And then you get out and you've got all these medications and you have to change your lifestyle and stop smoking. You have to exercise and everything else. So wouldn't it be great if we could step back, 5, 10, 15, 20 years and make these changes before the first sign of cardiovascular disease is a heart attack? Heart disease is still the #1 killer of women. And I know we're in breast cancer month and everyone's wearing pink, which is great, and we support that. But women still really need to think about heart disease because that is so impactful to their lives. And unfortunately, a lot of the studies have been done on men, and there hasn't been enough information about women and which medications or supplements or lifestyle interventions work for them. So we're still pushing the education knowledge. Cardiovascular risk factors. Some are modifiable, some are not. So being physically active is something we can change. High blood pressure is something we can change. We call it dyslipidemia or, abnormal lipids and stuff. That's something we can change. Diabetes is something we can change. Obesity or weight is something we can change. Metabolic syndrome, which is kind of a combination of abnormal sugars and weight and stuff, we can change that. Smoking, we can change. Can't change our age. As we get older, we do have an increased risk of cardiovascular disease, and we can't change our genetics. However, we always say in our practice and stuff, your genetics, that may be something that you've been blessed with your parents' genetics, but your genetics is not your destiny. Your environment is. Your environment will turn your genes on or off depending on what you do. So if you have a great diet and exercise, you can keep your stress really well managed, you turn off those genes that your parents gave you that you went, oh no, I don't ever want that to happen to me. But if you have those genes and you have a very poor lifestyle, you smoke, you don't exercise, you're under a lot of stress, you could turn on those genes. So we always kind of be aware of our genetics and stuff and how impactful it can be to us. How are we doing on the sound? We're okay? All right, so I wanted to kind of spend a few minutes on talking about functional medicine approach. Maybe I'll stand over here, a little easier for you. So integrative and functional medicine are kind of terms that are being used quite often nowadays. So I kind of wanted to touch base and then bring the functional medicine approach to our talk today. So in functional medicine, we talk about these kind of areas: assimilation, transport, structural integrity, defense and repair, communication, energy, biotransformation, and elimination. Every disease has all of these components. Every single one, you can name parts of this. And so when we're talking about cardiovascular disease, we're going to look at all these sections of it. So assimilation is, what do we need to live? Well, we need oxygen. We need amino acids. We need minerals. We need vitamins. We need cholesterol. To make all your hormones, you have to have cholesterol. It's the building block of all your hormones. So that includes your thyroid hormones, your sex hormones, your adrenal hormones. So we do need some cholesterol. So when someone says you need to drop your cholesterol, how low do we go? Because we do need that cholesterol. So there is definitely that balance. So I want you to think about assimilation as being kind of like the person, okay? Transport, what do we need to move that person around? So we need carrier proteins. So I'll give you an example when it comes to cardiovascular disease. So the person is the oxygen. The carrier protein is the red blood cell. So that's the car. So the oxygen has to sit inside the car to be driven around to those tissues that need that thing that needs to live. So it needs that oxygen. So it's being driven around in that car. However, that car needs to go and drive on a road. In cardiovascular disease, what is our road? That's our bloodstream. Okay, so that is our road. So our blood vessels in our cardiovascular system. And now our cars, do we want to be driving into traffic or away from traffic? We want to be driving away all the time. We want to be driving into the least amount of traffic. So our bodies work by going from high pressure systems to low pressure systems. It just makes logical sense for our body. And so our body also depends on the needs that it requires. So just say you start running down the street. Which part of your body is going to need more oxygen? Oh, your muscles. So the cars are going to go down the roads, the blood vessels, to those muscles. Just say you just ate a big, huge meal. Where's our oxygen going to go? Right to our guts. So our bodies are going to take those roads and take our cars to those areas that we need. Defense and repair. Kind of think about, we've got our cars, we've got our roads. Guess what? They break down. So we need a repair system. So that's our immune system. And our immune system is always checking on everything. It's, oh, are you broken? Oh, is there something, is there a traffic jam on the road? Oh, do we need to fix this? Or immune systems are always checking out, making sure that our cars and our roads are working okay. Communication. Now we have to have somebody to communicate between the cars, the roads, what's going on. And so that happens through hormones, neurotransmitters, your brain hormones, and cytokines, so some inflammatory markers. And I kind of say that's kind of like our government agency. They're sort of let's check everything out, make sure everyone's working in synergy together. And then energy. How does all this happen? We need to have some energy. So our mitochondria are these little tiny parts in every single cell, and they're kind of like our power engines, and they make ATP. So adenosine triphosphate. I always get those. I don't know. We've learned it for so many years. But anyways, when you make ATP or you make this energy, you create a free radical. And then we take antioxidants to get rid of the free radicals. So I kind of think about your car, you're driving, you've got gas in your car. Oh, you've got exhaust. The exhaust is not the great stuff. And what are we doing to kind of get rid of that exhaust? So that's what the body's trying to do. And there comes in the biotransformation and elimination. That's our garbage crew and our cleanup. So what needs to be cleaned up? So all these little processes create products that need to be cleaned up. What part of our bodies biotransform and eliminate? Our liver, our kidneys, our skin, our lungs, all these systems kind of work all together. So you can have a system have multiple roles. I just kind of wanted to kind of bring it into the cardiovascular realm. And then the big whole thing on top of all of this is, what do your mental, emotional, and spiritual things going on in you, how does that impact our car, our roads, everything else? And so this picture here, this is the Institute for Functional Medicine. This is kind of one of their big trees and stuff. And I really love this picture and stuff because it talks about how we've got an organ system and then all these different organ systems together. And then you can see the functional organizing systems and core clinical imbalances. So there can be imbalances in assimilation and defense and repair and energy and transport and all these systems, and they all work together with each other. And then you have this mental, spiritual, is that mark in the right spot there? That mental, emotional, and spiritual influence. We've got our genetics, here, and we said whether that's turning those genes on or off. And then we've got our experiences, our attitudes, and our beliefs. On the bottom, our roots of our tree is really important. What do we do that impacts all these systems up to the top of the tree? Sleep and relaxation, exercise and movement, nutrition, stress, relationships. So in our practice, we are looking at your tree. We want to look at which organ systems are involved, looking at how are they interplaying with each other. And then when we come down and then assessing those, and then we come down and look at your history and stuff and sort of see where this beginning story started. And then looking at our roots, going, where can we make the most difference and stuff. And the roots are sometimes the hardest part to do. It takes a lot of self-change to kind of incorporate lifestyle changes. This is how we kind of take a look. And so when you hear someone say, what is functional medicine? This is, or integrative medicine, this is what it is. It's kind of taking all the parts and putting them together. If you want more, we can talk more about that at the end. So let's get on to our talk. So we're going to talk about the blood vessels. So our blood vessels and stuff, things can happen to them. Those are, we said, our roadways. And so kind of things can happen to them that can cause them to be disrupted. You know, they can get inflamed. And usually what causes the inflammation is our immune system or that oxidative stress that happens. Our diet can inflame our blood vessels, and emotional stress can either constrict or relax our blood vessels. So that's kind of the early thing that happens to our blood vessels, and that happens all the time. You might have, maybe gone through McDonald's on the way here, and then you were in rush hour traffic, and then we were running a couple minutes behind, and then you're wondering how long your babysitter is going to be, and then all that stuff could be causing inflammation. But that's normal. That's our day-to-days and stuff, and that's a normal response. However, if that keeps going on day in and day out, we can get what's called endothelial dysfunction. So that lining starts to get off. So that's our nice, smooth, brand new asphalted roadway starts to get a little wobbly, a little cracky and stuff, and so it doesn't react the way we want it to. So instead of contracting and relaxing properly, it doesn't. It stays more stiff. And then chronic, so think about stress. You just kind of chronically clamp down. So if someone checks your blood pressure and you're under a lot of stress, it's like, oh, your blood pressure is really high. Yeah, well, I'm under a lot of stress. Well, we hope that stress goes away so that blood pressure can relax. So the blood vessels are this dynamic kind of constrict and relax, because we want them to constrict because it needs to shoot blood flow to areas of the body that needs it. But then it needs to relax in other areas. Over time, if we constantly, keep getting onto our roadways, we can get this abnormal compliance. So now basically functional changes start to happen. So I always kind of give the example is, think about your blood vessels as being a hose. Do you want to put water through a hose in the summertime or water through the hose in the wintertime? And I think everyone would agree in the summertime. You get this nice flexible hose, the water comes out of it nice and smooth. Versus, or even an old hose. The old hose, it's that stiff old hose and you can't unwind it and stuff. You try and put it, the water goes shooting through it really, really fast. Or in the winter time, it's that really stiff hose and stuff, and you had water shooting through it really fast. That's what we don't want to have happen. We want that blood vessel to constrict and relax and stuff. We don't have the stiff blood vessel. Because remember we said our roadways can start to get a little uneven. If you're pushing water through, or a fluid through an uneven roadway, what's going to happen? It's going to start causing this change, this mechanical change. And so our engineering people can talk about eddy flows and Bernoulli's theorem and all that interesting stuff. But instead of this water flowing through nice and smoothly, it starts to swirl and spin and wave and stuff. And that's kind of what we don't want our blood to be doing. Because we have, remember, those little cars in there. Do you want your car driving straight, or do you want your car being always twisted and bounced up around all the time? So that's where this abnormal vascular compliance starts to be really more of a concern. And we can actually start to test that nowadays. There's some really interesting, cool tests that can start to look at that. And then a permanent change is now all of a sudden we have permanent structural changes. We've got the inflammation, our immune system's upregulated, we have oxidative stress going on, and we've got speed bumps in the artery walls. And so our cars are hitting these speed bumps, it's creating inflammatory reaction. The body doesn't like that. It brings other components in to try and fix the roadways, but it can't fix the roadways because the blood just keeps coming. And so that's kind of how this gradually happens. We get inflammation, little dysfunction, compliance changes, and then eventually we get this atherosclerosis. There is a couple of things that can change atherosclerosis though. So there is hope that if we get down to level 4, it's not, a foregone oops. So, all right. So how does a plaque form? Dr. Tetlow, I'm going to drink some water if you want to kind of touch base on some of this.
So Annmarie has only covered the entire schema for functional medicine. That slide, the series of slides, which had the list of all the different aspects of every chronic illness and then the tree. So she only covered the entire schema for how you think about the body and how you can think about any illness, and then kind of went through those stages that, we were talking about blood vessel health and like a minor insult and how it can progress. So this is, covering like textbooks worth in a very short amount of time. So I think that it's a very powerful thing to be able to describe in a short period of time what a functional medicine approach is. So you're a tree, and there is a process, and there's a connection with putting an organ center in the middle, and then seeing those aspects, seeing those parts. I just think it's a really powerful thing to be able to communicate in a succinct way.
I can keep going, and then you can show the next slide. You can get into details. Yeah. Sorry, my throat gets really dry and stuff in here. So our plaque formation steps, we talked about that higher blood pressure now, so our roadways. So what are, remember we have cholesterol that also floats through our bloodstream because we need it to be transported around to help make those hormones. So the elevated blood pressure now takes that cholesterol and it starts to push it through the cell wall. So you think about our road, so there's cracks getting our road, well, what's getting down in those cracks? And we all sort of know, what happens when you get like freezing and thawing in the water, and then all of a sudden that little bump on the road is now this major pothole, and then the roadwork never comes out and cleans it up in time. So we get that chronic inflammation going on, which makes that endothelium, that lining, more permeable, so more things start transporting through. So those small little LDLs, or low-density lipoproteins, start getting through between the cracks. They get oxidated and glycated. So oxidated basically means that they just get damaged. Think about, iron or copper when it gets oxidized. So if you have those, I'm originally from Canada, so if you see the national buildings there, they have all copper roofs, and these beautiful copper-looking roofs. In, a few years, those roofs are black. And then in a few more years, they're green. That's oxidation. So it changes. So we can also look at iron and stuff, or pennies. Look at copper pennies. You can see that sometimes too. So that's what actually can happen to the cholesterol, is it can change and get oxidized. When our body starts seeing oxidized LDL, it goes, we don't like this. So it starts bringing along things to clean it up. So macrophages and platelets are things that they do to help kind of clean up. However, they can't clean up the damage, we said, because blood keeps flowing through in that area. So I always say it's sort of like a car crash happening, and now you got the emergency vehicles, you got a secondary crash because people are trying to watch what's going on, and then there's all these spectators, and that's your blood kind of whipping by, sort of going, oh, there's this plaquey thing kind of starting a bump in the road, and it's starting, and then it keeps building and stuff. The body's trying to clean it up as fast as it can, but it can't because there's blood. It's like they can't shut off the roadway and say, all right, let's clean up the crew, and then we can open up the roadway again. It doesn't happen that way in the body. So the more our body keeps getting this exposed to this kind of bump in the road or this inflammatory process going on, the more inflammatory processes it brings on. So it's kind of like gas on a fire. It keeps getting irritated. And then it creates this plaque, and it starts to calcify and then crystallize, and then it can eventually rupture. And then a thrombus is basically a blood clot. So that is a picture that Dr. Tetlow can kind of talk about a little bit more.
So this is like a progression picture. So I think, so this is the way we do right?
Yeah.
So, that's hard. So this is the inside of our circulatory system. So this is our blood vessel, inside of our blood vessel.
A roadway.
So this is inside of our roadway. Are we in a tunnel, Annmarie?
Sure, we can be in a tunnel.
We're in a tunnel. So the space inside the tunnel is extra wide over here. And you can see the space inside the tunnel is getting actually more and more narrow. So there's actually going to feel like more pressure in the blood vessel itself. So we're seeing a progression from over here in this direction. See, there's kind of like an arrow that goes this direction. And one thing that's really nice about this slide is that these little names are actually blood markers. And so we test these. So this is why the science of the functional medicine is also so powerful. So we're actually looking at these markers and can test these, and can also kind of figure out how far along we are in this process of being a healthy blood vessel to becoming more and more unhealthy blood vessel. So come on in at any time, Annmarie.
So, I mean, I think damage, disease development, vulnerable plaque formation, and even a rupture. So this is like a little volcano where we have an accumulation on the inside of the blood vessel. So that's the endothelial disruption. So Annmarie's talking about the road is starting to get a little bit rough and buckle. I love that analogy. That's your analogy.
Okay.
So, I mean, I think that's, and you can see how right here, this is the rupture, where actually it was, the inside was smooth, it was rippling, but then actually you can have this process of this accumulation rupturing outwards, which is actually quite an inflammatory event. And there's a disruption of that lining, and you can actually eventually get a clot. So we're all familiar with how, there's mortality associated with having a stroke, having a heart attack. That's just a blood vessel in your heart or a blood vessel in your brain. It's got a clot in it. So that's this heart attack or stroke phase right here at the end. So when someone goes to the ER and we test their labs to see if they're actually having a heart attack, we can test these markers. So have you ever heard of trending the troponins? That means we take a couple of time pieces and we see whether or not the troponins are going up, and we can tell whether or not there is, and those are particular markers that relate to heart muscle. So we can localize the blood clot in the heart and actually see where we are along this phase, or we can help to rule out a heart attack at the time. And this is really what's happening physiologically. And we can actually use markers to go way upstream to see, are we in the beginning of the process, and what do we need to make it earlier and earlier and more preventive, what steps we can take. And then we can also show patients their progress. Like, let's say we'll talk about markers in a moment, but there's an HS-CRP. Do you see that, or is that a little bit fuzzy for you? That's a high sensitivity HS, high sensitivity CRP. That's just an inflammation marker. And we have patients that come in and they have high values. And then we do interventions and we retest the marker, and the marker is a lower value. So that's an example of literally having an effect on this progression, helping to reverse the progression, and you participating and seeing your role, like what steps did you take that helped to make that marker improve. So this is it's a very powerful slide.
Thank you.
You gave me this one, that was very nice.
Yes,
Thank you so much.
So just a couple little things in here.
Yes.
Remember we talked about that blood vessel and stuff, as it gets narrower and narrower, our stream, our flow and stuff. So we have that hose in the summertime. So that's what would be at the beginning, this nice, soft, flexible hose. At the very, very end, you'd see this really stiff, narrow hose, and water would be going through, the blood would be going really fast through that. Well, that's where we start having those little eddies, flows and stuff, and we start bumping into our little, our little kind of bumps there and stuff. Now, what everybody thinks about plaque and stuff. So, and this is, and even in school and stuff, I remember this. It's like you have the inside of the blood vessel and you plaque inside. Well, that can happen. But remember, 62% of all women and 46% of all men who have a heart attack, that's their first sign. Remember, that's their first sign of cardiovascular disease is a heart attack. Well, is that because it plaqued on the inside? Not necessarily. Those people are usually the ones we call unstable plaques. They're actually under the lining of the endothelium. So they're underneath. And when we go through with the camera and stuff, and people have all, heard about people getting their, what's my term?
Like a catheterization.
Catheterization, yes, her catheterizations. Your vessels look great and stuff. Well, you're only looking through here. That little camera can't take a look underneath the cell wall and see, maybe there's a big plaque formation. It can see if it's a little narrowed. It can see if there's plaque inside here, but we can't see underneath. And those are the ones that scare us because we don't know we're going to rupture. We don't know if they're soft, gooey plaques or if these hard, crystallized, stiff plaques. So sometimes people hear about calcium scoring. Oh, my calcium scoring and stuff. Calcium scoring is hard plaque. It's probably not going to move because it's so stiff. It is going to narrow your vessels. So it's going to increase your risk of blood pressure. But those ones don't tend to move. It's these soft plaques and stuff where they rupture. Those are the ones that concern us. And so there's still some new tests coming out, and these blood markers are a great way to follow them. But those are the ones I think people need to really know and understand, especially if there's been a history of someone who having a sudden event. And you're like, I wonder if I should get my markers tested and stuff. So what causes, now we're going to go into, not so much looking structurally, we're going to cause what causes dyslipidemia. And I like the term dyslipidemia as opposed to hyperlipidemia because not everything high is always bad. So dys means it's just abnormal levels and stuff. So what can cause it? Chronic infections. So a big area that people always forget about, really common cause of heart disease, is in your mouth. People who don't have dental work done, they've got a lot of cavities, they don't floss their teeth, they don't go see the dentist. High amount of bacteria, and that gets into the bloodstream, and then it floats, those little bacteria float around your bloodstream, and they cause havoc everywhere. So they cause this inflammation, and they can cause this process to start. So, and they've shown and stuff, just by flossing your teeth, you can decrease your risk of a heart attack. And I can't even remember the numbers and stuff, but it's dramatic and stuff, just by flossing. But it's getting to the routine of doing that and stuff. And going to see your dentist regularly is really important. Another, chronic infection that can cause heart disease has actually been linked to H. pylori, which some people have been diagnosed with and stuff, and we can eradicate that. But there are a lot of other infections that we can go through that could increase your risk of heart disease, because what the body does, it's called molecular mimicry. It kind of sees something foreign, and then it thinks your body is that, and so it sort of acts on your body in the same way. And it increases the inflammation, and it causes this dysfunction, and eventually that atherosclerosis can start. Toxins can definitely cause dyslipidemia, heavy metals, having too much iron in your body. There's a condition called hemochromatosis and stuff, which is elevated levels of iron. They have a higher risk of heart disease and stuff. Very easy for us to treat sometimes. We just take them off a lot of anything iron food-wise, and we get them to go donate blood, which is so wonderful and stuff. But being able to identify those heavy metals is really important. One thing I wanted to talk to you about, it's kind of a newer concept, and we're sort of tossing whether we should throw this out, it's a term called endotoxemia. So every time you eat a food, you create endotoxemia. You create a toxic event in your gut every single time you eat. Eating is not the best thing for you. It actually creates a really terrible environment, but it's okay and stuff. Because what it does is it has your body break down and realize, okay, what do we want to take? What do we don't want to take? And so endotoxemia leads to inflammation actually inside that stomach lining, that enterocyte, the cell in the stomach and stuff. And that can open up little junctions between each cell in your stomach, and then stuff that's floating around in your gut can actually go through. And it's every time you eat that happens. And it's called endotoxemia. However, your body's really smart, and your body, think about how many times we eat, our body goes, we'll repair after a meal, we clean everything up, everything's good. However, if we keep eating certain foods, our body just can't keep repairing itself. So those cells kind of open up, things go through, body goes, oh yeah, no, we're fine, cleans everything up. Oh, but you keep exposing me to these certain foods and these certain bacteria that are floating around in my gut. Now we're causing a little inflammation. We're causing some immune markers to go up. I don't like this going on. And so they've actually shown that a high-fat, bad-fat diet and the refined carbs, so we call it the standard American diet, tends to cause more of this endotoxemia, this inflammatory response in our gut, and it lasts longer and longer and longer and longer for your body to repair it up. So typically you eat a food, and within 90 minutes, your body should be able to clean up all this endotoxemia going on. However, if you eat a high carbohydrate diet, it takes over 2 hours. And then if you eat a high carbohydrate plus a really bad fat diet, it takes even longer for your body to clean up. So think about, breakfast at 9 o'clock, I ate McDonald's, the Egg McMuffin with the little hash browns. 2.5 hours later, I wanted that Big Mac. And then 3 hours later, I had some, a candy bar from the machine at work and stuff, or a donut or something. And then a couple hours later, we had some pizza at home. All of a sudden, your body is exposed to this inflammation, and it's like, can we settle down? Can we slow down? So you don't ever give your body a chance to kind of repair itself. So every time you need to eat, we want you to eat certain types of food, let your body get this reactive thing going on, clear itself back up again, and then next meal, same thing again. So we need to make sure we kind of really watch what we're eating and how much time between meals sometimes, which is important. Interesting though, however, is this endotoxemia that happens with every single time you eat can actually be blunted by certain foods that you add them to your diet. One thing is red wine or resveratrol. And if you all think about, the whole, French, they eat a really high fat diet, French, and there was a book that came out, why the French don't have heart disease. And some of the theory is because they do eat, smaller portions, they have more time between their meals, and they have a little bit of wine with their meals. And maybe that helps to calm down some of that
They sit
endotoxemia.
down when they eat.
And they sit down when they eat, yes. Other things that actually can lower this endotoxemic reaction, orange juice, a high fiber diet, resveratrol, which is what's in red wine or red grapes and stuff, and curcumin. So curcumin is curry, and so if you look at kind of a lot of Indian foods have a lot of curcumin or curry in it. Actually, India has a very toxic world environment. They have a lot of heavy metals and a lot of toxic things going on, but yet they have one of the lowest incidences of Alzheimer's. And one of the theories behind it is because they eat a very low inflammatory diet with a lot of this curry spice into it. So maybe it's protecting them something from environmentally. Remember how we said genetics? They get turned on or turned off by what we do in our environment. So maybe there's some genetics that get turned off by something that we're doing in our diet. So just thought it was really interesting is that there's things that we could do. Not that we're advocating, drinking at every single meal, but, you can sort of see what foods can definitely help, especially the high fiber and stuff. So we're going to spend some time now going through testing options. So to look at a cardiovascular panel, our cardiovascular profile and stuff, there's a lot of things we can test. And now when you come to our clinic, we don't test all of this. We can eventually if we want to. There, some of it can be a little expensive. We try and keep our costs very, very low. The companies that we deal with for our cardiovascular panels, we have no responsive or relationship with them other than we get their lab results from them. And we, all of our labs and stuff, patients know upfront what their costs will be, and there was never anything billed beyond that. So we try and keep those costs very, very manageable for our clients and stuff.
I think that's important, that we receive no benefit from any testing we recommend. So I'm glad that you mentioned that, Annmarie. Also, when we do like a really nice full cardiometabolic panel, it's completely free for any Medicare patient that comes to see us. And a lot of these tests that are listed here are insurance reimbursed tests for Quest, LabCorp, any of the generic like Health Network labs, Abington labs, any of the places where you have all your conventional labs done. And you don't need to worry, as Annmarie also said, that we don't do all of these tests. Our job is to partner with you and figure out what are the right next steps and what will be most meaningful. And sometimes it'll be just a few lab markers, and that's how we figure and watch progress. And you become familiar with the lab markers, and you know what you're testing, and you actually can sometimes feel very motivated about your lifestyle changes while you're getting ready to get your next testing done.
Yeah, so I'll kind of go through why we test certain things. So a CBC, so your blood count, we're looking at CBC, are you anemic at all? What's your iron status, your iron stores and stuff? Because we want to see, that hemochromatosis, do you have too much iron? Do you have too little iron? If you have anemia and stuff, remember, we talked about, the little cars? So the little oxygen's being carried inside those cars. If you don't have enough of those cars, what is that heart going to have to do? Oh, boom, 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 going to be to push those cars faster and faster and faster. So the heart's going to get really stressed out. The lungs have to work a little bit harder. Now, if you go, I'm going to start exercising and you're a little anemic, wow, you're really stressing out your body. And fixing someone who has low iron is really easy. We just, add some iron into your diet and stuff. So this is something very simple for us to take a look at. Urine, we want to take a look at the kidneys, and a CMP, which is a complete metabolic panel, which kind of looks at, your kidney and liver function and your sugars. It's kind of a blend of a whole bunch of little things. Why kidneys are important is because there are some hormones that the kidneys actually produce that control blood pressure and stuff. So we definitely want to make sure we're keeping our eyes on the kidneys. What's really important about the CMP that we tend to look at, and then we add a couple other things, is your glucose, and then your insulin levels. And then there's a marker that used to be used in diabetes called a hemoglobin A1C, but we use it now pretty much all the time. It tells us how your sugar's been running for the past few months. This is a really interesting statistic, is that when you see your glucose and goes, oh, it's under 100, you're doing good and stuff. For every point above 75, that's a pretty low number, every point above, 1% increased risk of cardiovascular disease. So if you're already at 100, you have a 25% increased risk of cardiovascular disease. So blood sugar is really important. And when we start looking at diabetes and metabolic syndrome, blood sugar is a really easy way for us to look at way, way, way back and stuff. And I've worked with a lot of younger individuals and said, hey, you don't fix this now. We're going to be looking 10, 20 years. and you're going to be coming to me with all these medicines, and because that's what we can do at that point in time. So we don't want to do medicines. We want to fix this early on. So blood sugars, wait until they get above 100. We need to do this way earlier.
So I had a patient this morning who is a pre-diabetic patient, so they're kind of borderline with their blood sugar, and they're on 2 medicines to help prevent diabetes. He was looking at his blood work. We had a hemoglobin A1C, that's the marker for 3-month average of blood sugar. It was 5.9. So if anybody knows your numbers for the 3-month average for blood sugar, he was really happy because it meant pre-diabetes. It means he's not in the diabetic range. He's like, look, we're doing good. We have this pre-diabetic number. And then we looked at the random glucose, and that glucose was 127. So fasting, he hadn't eaten for at least 12 hours. His resting blood sugar on that complete metabolic panel is 127. So if you count that as 1% increased risk for every point above 75, he's not doing quite as well, right? And he's on 2 medications. So it's not about giving him bad news. It's about kind of reevaluating the test and giving information about what's really going on with blood sugar and how it really does increase his risk for cardiovascular disease.
Yeah, and I know Dr. Tetlow does as well. We don't treat labs, we treat people. However, from doing this from a long time, cardiovascular labs, I do tend to put more weight on them than I do on a person, because I have seen the impact of adjusting these numbers and stuff, and seeing the physiology behind it and the research and stuff. So I do put a little more weight on these lab markers, and I think it's really important. And we don't do the labs for us, we do the labs for you. So you can say, this is me, and it gives you power to make these changes and do some lifestyle interventions. Liver panel, we talked about our biotransformation. Our liver is our big area to get rid of our toxins, and so we need to, our liver, I should say, and gallbladder, we need to keep those really healthy, because that really helps to kind of clean up all those extra processes that go on in the body. Vitamin D3, that's part of our immune system, and actually vitamin D is not a vitamin, it's actually a hormone in our body, and it works on basically every single cell and everything. It does so many things, so we definitely want to make sure we keep watching that vitamin D. Our stress hormones, there's the emotional part of our matrix, our lifestyle, how stressed are we? We want to look at that. And we were talking earlier and stuff when we were going through, our medical programs and stuff, they talk about this heart condition, and I always get a Takotsubo. Does that sound right? Takotsubo cardiomyopathy. So basically it is when one part of you remember how we said the top part of your heart squeezes, and then the bottom part of your heart squeezes, and it pushes blood out through the body. So the ventricle, which is the big part that squeezes the blood out to your body, all of a sudden goes bleh. And it just goes, bleh, and it doesn't want to contract. So this condition is more common in women than it is in men. And it's related to an emotional or physical trauma. And it's called broken heart syndrome. And that's actually, they found it in Japan in the 1990s and stuff, from women whose spouses passed away, and all of a sudden they came in complaining of like a heart attack. And they weren't having a heart attack, but this part of their heart that pushes all this blood to the body went blah. And stuff. So that's what stress does. The stress can shut like the heart muscle off. That's amazing what the body can do, what stress can do to the body. It can repair itself, which is one really good thing. But I think it's just fascinating that, what stress can do to our body. It makes such a huge, huge change to our body. And this isn't something that was just, graduate. This was this emotional trauma that sort of goes on. Our sex hormones and stuff are an important area to look at. Estrogen, when we're younger and stuff, we have estrogen, and that is protective to heart disease. As we hit menopause, then our estrogen levels change. Maybe not so protective. Progesterone is kind of gotten progesterone's important. Our hormones need to be balanced and stuff. And the Women's Health Initiative basically said that, progesterone was bad and it caused heart disease. And then we actually teased out the information. It was progestin, the hormone that was used for postmenopausal women, that really increased the risk of heart disease. And so I always want people to understand there's progesterone, which is what your body naturally makes, and there was a drug that came out that was progestin. These were made from horse urine, basically. And we saw when the hormones weren't balanced properly, women's risk of heart disease went through. Testosterone. Testosterone's kind of, it's got a sweet spot. Too low testosterone in men, heart disease. Too high testosterone in men, heart disease. So there's a sweet spot for men to be on where testosterone is very, very protective. So we got to make sure we keep our men in the middle there too. Thyroid's really important for us to look at. If the thyroid's not functioning properly, You can run some really funny abnormal rhythms, one commonly called atrial fibrillation. So the top part of the heart just starts quivering a little bit. And so remember we said that blood starts to spool. And remember, you have those little cars going in. Well, sometimes those cars, if they start spinning around, start to join together. And there's a little tiny clot that forms and stuff. And our bodies have these little clots all the time floating through the blood through. So think about it almost like a bus. But our liver and our kidneys, they kind of clean all that stuff out. But if that clot gets too big, are we going to start throwing clots in places we really don't want it to be? So thyroid's a good, important area to look at. A micronutrient panel is a panel that we tend to use quite often. It takes a look at what your body's actually utilizing as a nutrient, not just what's floating around in the bloodstream. So it's a very intense marker for our nutrients. Fibrinogen is our clotting, so we want to make sure someone at higher risk for clotting and stuff. The advanced lipid panel, I think I'll show you in the next couple of slides, the kind of lipid panel we like to look at that gives us a lot more information. As Dr. Tetlow talked, the HSCRP is a very important marker to keep following. Remember we said that's your communication. This is our communication of what's going on in the rest of the body. It's a marker of those inflammatory markers, and it's a really good predictor of cardiovascular progression. Homocysteine is a marker of the red blood cells kind of getting stuck together. It's also a marker of if you've had a poor lifestyle and maybe that standard American diet. And as we change things, we see those homocysteine numbers change. ApoB and ApoE, these are measures of these lipoprotein particles, and I'll talk more about them on the next slide and stuff. The lipoprotein particles, the ones that are more risk for causing atherosclerosis and stuff. ApoE as well, we can use. That one we talk a lot about with Alzheimer's risk. There's an ApoE marker and stuff. If you have it, you have a higher risk of Alzheimer's. Omega-3, remember everyone heard about omega-3 fatty acids and stuff? We can actually test what your body is utilizing in your body, so it's not just, oh, I'm taking my fish oils and stuff. Are you actually utilizing your fish oils in your body? The lipoplaque-2, so LPLA2, so we call it lipoplaque-2, it basically, remember we talk about those unstable plaques, and we're like really nervous because we really can't see them when we're looking with the camera and stuff. This is a really good marker to look at those unstable plaques. So if you have this marker high, you have a higher risk of these little plaques, and so increased risk of those stroke and heart attack markers. Adiponectin is it's a hormone that controls metabolism. Leptin's sort of like its alter ego a little bit, and it regulates kind of appetite, and it's our satiety hormone. So when that leptin marker tends to go up, we tend to we feel full all the time. So we want to make sure that that leptin marker is okay, otherwise it increases our risk of obesity. Myeloperoxidase is an inflammatory marker. Lp(a) is an extremely, we call it atherogenic or plaque-forming lipoprotein. It does increase your risk of clot formation, and it's genetic, and I have it. And I have an absolutely perfectly normal-looking cholesterol panel. It looks beautiful, except for that little marker. And so it goes, it's genetic. What can I do about it and stuff? Well, it still goes back to lifestyle. And there isn't a medication, and there really isn't a supplement to change that marker. It's just a marker I know. Okay, I know it. But that means I got to do all these other things so that marker doesn't impact everything else and stuff. So it's really interesting. You can look at, I'm normal. It's good. It's good. Oh, maybe I should look, because I do have heart disease in my family. And, when you look, I have no risk. But you always have to keep your eyes open and stuff a little bit. Telomere testing and stuff, that's some of our newer, aging, how is our body aging and stuff. And then there's some genetic markers. There's a marker called 9p21, and it's a marker of basically an inflammation going on in your body. And I don't know if there's anything else you want to touch about these lab tests or anything.
Extremely thorough. I think the most important thing is that we always partner with you to choose the right tests. It's also really helpful when you're in the office with Annmarie or any of the providers in the clinic. Basically, we want to help to make these markers make sense for you, right? So we want you to have a relationship with the labs and understand them and see how what you're doing is actually, that's why we really like to pair the improvements that you make and have you understand what's going on, so it helps you to see what's happening and what's in your control. So I think that was very thorough.
You want to talk about the LPP panel a little bit?
So size matters.
Yes. So what this is referring to is sometimes when we get cholesterol panels, we're looking at the number. What's the total cholesterol? What's the triglyceride? What's the good cholesterol? That's the HDL, right? So what's the bad cholesterol? which is the LDL. Actually, the LDL, the bad cholesterol, is actually the one that helps to form the backbone for all your important hormones. So it's not actually bad cholesterol. And some of the patients who come to us with really low cholesterol numbers, we get very concerned about them because you really need those backbones for all your hormones. So this is talking about size and density. So we're not just counting particles, like the number of the total cholesterol and it going up and down, being high versus low. We're talking about the actual size. So it's a large particle. We like to say buoyant and fluffy. Or is it small and dense? So this is quality, not quantity, for your cholesterol particles. And this has to do with your liver health. Your liver is managing your cholesterol. It's helping you digest fats, and it's helping you to decide how much cholesterol is circulating in your blood, and that's indirectly helping to create plaques or more or less plaques. So it's talking about here, you can see LDL cholesterol measurements do not determine the number of LDL particles. So we're looking here actually different people. There's Jerry, Susan, David, Maria, low risk to high risk. And we're actually seeing this size particle, and then we're going to this progression, and we're seeing additional smaller sizes. So Maria actually has smaller and dense and has the highest risk. The lipoprotein particles are actually the particles, that means quality as opposed to the number. This is actually determining risk to a much larger extent than just counting and looking at numbers. So quality, not quantity. So I think the reasoning behind that is, let's say you have a lot of small, dense particles, those can actually pack in and create a plaque. Whereas a light and fluffy is not necessarily going to stop and create a little and set up shop as a plaque inside your, or next to, or on top of, or underneath your endothelium, that inside of your blood vessel. Each of these people, these individuals, has the same LDL cholesterol. So you check it on the labs, the total LDL is 125. But the risk is completely different depending on the quality. Are they light and fluffy? Are they small and dense? And then we're really interested in the health of your body. We're not just counting numbers, and we're looking at the health of your liver. And the health of your liver is playing a huge role, whether or not the quality of the particles are the quality that we want. And there's a lot of things that we can do in our lifestyle with our diet that help to create healthy, large, buoyant, large and fluffy particles.
Thank you. Thank you. So remember at the very beginning I said, when you have that endotoxemia and stuff, so every time you eat, those cells open up and the small, dense LDLs can travel through, and especially the ones that have been oxidized or changed and stuff, and that's what causes this inflammatory response. So Maria's got these small, little, dense ones. They're sneaking through. So we don't like those. And so I always sort of think of this as sort of being like the package that's holding all the cholesterol together. And I always use big and fluffy, or like tennis balls. What do you want thrown at you? A big fluffy pillow or a tennis ball thrown at you? I'll take the fluffy pillow. And what's interesting to note though is statin drugs and stuff. And I'm not saying this is not an anti-statin drug. There are people who are appropriate to be on statin drugs. Statin drugs will lower the number, but it does not change the particles. So it can lower it from 125 to 100, but it doesn't change the particles. And that's a really important thing to know. So when someone goes, oh, well, you've just dropped your LDLs, it's great. But did you change your particles? Because that's what we care about for heart disease and stuff. That ApoB marker that I kind of talked about before, it does correlate with your LDL particle number. So if you don't do this fancy little test, you can always ask for an ApoB, and that can give you sort of an idea of, where are you? Are you small, little, dense particles, or are you big, fluffy ones and stuff? So this is actually, and this is the schematic of one of the tests that we do, this lipoprotein particle panel. And we get it also the actual physical numbers. And so how I kind of talk about the cholesterol, it's being carried around in these lipoproteins, these little cars and stuff. And so we talk about, the good cholesterol, the HDL. We talk about the bad. And I always say there's the good, the bad, the ugly, and the oh my gosh and stuff. So if you have the oh my gosh, then we have to do some work and stuff, because that's those small, dense particles that we say cause so much damage. So LDL, so if you take a look in here, this LDL 1 and 2, kind of right here on the bottom, that's big and fluffies. We like those. This person's got a lot of those particles in there. LDL 3, those are our medium-sized ones. So instead of being our big fluffy, beach ball. Now maybe we have a volleyball at you here. And then we start going into LDL4s, which are over here. Those ones start being our tennis balls and stuff. So we don't like these. And then all the way over here on the left side, and it's kind of always confusing to people when you're sort of like, but why am I not going smaller and smaller and smaller? It's just, they separate it out. These particles over here are called remnant lipoproteins. These are really atherogenic. So these are the ones we go, ugh, those are really, really ugly ones. So if you have these ones here called an IDL, a VLDL1, a VLDL2, and especially a VLDL3, that's yucky, yucky, yucky. So we have to really try and work on getting rid of those ones. So when you do a typical lipid panel with your requests and stuff, it's just going to tell you LDL. Just LDL. It's not going to break it down into LDL 1, 2, 3, 4, IDL, VLDL1, and then VLDL1, VLDL2, VLDL3. Wow, do we have power when all of a sudden we can get these numbers? We can sort of say, wow, there's my risk. So you can either be the Maria, or it can be, what was his name, Joe? Jerry on the other side. So that's really important, I think, for people to really understand that. And then HDL. So there's a couple things about HDL. HDL is kind of like our garbage truck. It comes and cleans up the bad stuff. And then there's different types of HDLs. There's HDL 2B, 2A, and then HDL 3. 2B is like your big old garbage truck. And HDL 3 is kind of like your garbage can. It'll pick up stuff, but just not very much. So we kind of want big old garbage trucks cleaning up our garbage. So the HDL2B is more protective. Interesting, some new data coming out, and it's actually been around for quite a while and stuff, is someone looks at your panel and goes, oh, wow, you have a really high HDL. Oh, look, it's 99 or it's 100 and stuff. That's not good anymore. Really high HDLs we're actually thinking are potentially not helpful for you. Especially it can cause more inflammation going on in the body. And if you have metabolic syndrome and diabetes, it's more of a risk actually than a help. So breaking those HDL particles down into the 2B, the 2A, and the HDL3 gives you more information and stuff. So having just a high HDL and say, oh, that's great, that's great. Not all these all the time. So I think you have to take that in context with, do you have the other inflammatory markers like that HSCRP? Do you have a lipoplaque? Do you have a LP little a? And then you can sort of say, oh, all right, here's our risk now and stuff. So, all right.
We also could mention that this is an example of a SpectraCell
cardiometabolic
panel.
Yeah.
So this is a test that's a one blood draw, and it gives you all the important markers for cardiometabolic evaluation. And this is free for Medicare. Fairly low cost for me and Annmarie, who we have insurance.
I think it's like 125 or 140.
For
Yeah, I think it's like 125 or 140
And we
dollars.
also have the option of choosing some, rather than doing a specialty test,
Yep.
we might also do insurance reimbursed labs and just pick the labs out and create the metabolic panel.
Yeah.
But you get this great picture, which is really helpful because you can see the difference between before and after.
Yeah, and interesting to note, just from an insurance perspective too, the labs that we pick and stuff, we pay an upfront copay cost and stuff. It's actually cheaper for me to do this test than it is for me to do a standard lipid panel with Quest, just the way my insurance is and having a high deductible and all that sort of stuff. So it's interesting to sometimes note that these tests, even though they seem like they'd be really more expensive, aren't all the time with our insurance nowadays. And so you have to kind of look through things a little bit. So, and how it keeps changing. So let's go into some fun stuff. Let's go into diet for preventing cardiovascular disease and stuff. So we can, remember we said when we're talking about cardiovascular disease, we do want to kind of change those lipoproteins and stuff. And diet can, and has been proven to change us from having those small dense particles, getting rid of less of them and creating and shifting it more into those big fluffy particles and stuff. So helpful foods, plant sterols, soy actually does help from a cardiometabolic perspective. Almonds, fiber is really important in the diet, omega-3 fatty acids, and green tea. And so I'm going to kind of, there's like 4 little things I want you to remember at the end of the night from a health perspective. You can remember green tea decreases cholesterol absorption. Always remember that. Green tea helps decrease your body absorbing that cholesterol in a bad way. Drink green tea. When we talk about fruits and vegetables, really important stuff. Vegetables are really high in potassium and stuff. That is important from a heart disease protective measure and stuff. Fruits are good to have in our diet. Maybe 2 to 3 up to 4 servings a day, depending on the size of your serving. The ones that are most cardioprotective are your reds and blues and purples and stuff. So your berries. your blueberries, strawberries, all those. Pomegranates, actually, if people have heard of ACE inhibitors, they're a type of blood pressure medication. Pomegranates are a natural ACE inhibitor, and actually so are beets as well. So beet juice and stuff too. You don't have to remember that one. The heart, what's interesting about the heart and stuff is the heart does not like to use glucose for energy. It actually likes to use fatty acids. Interesting. And so I always say, you have to eat a low-fat diet. But guess what our heart wants as an energy source? Fat. But we want those good, healthy fats, which is really important. Dark chocolate. I always got to add this one in. Dark chocolate's important. And a piece or two of dark chocolate, not the bar and stuff. But dark chocolate does lower your blood pressure, and it does decrease your cardiovascular risk. So we always encourage people, if you need a little sweet treat, those are great to have. Eggs. I just want to kind of touch on the egg topic. Eggs do not increase your risk of mortality from heart disease, stroke, and cardiovascular disease in both men and women. It does not alter that endothelial function stuff. Eggs were kind of, no, you can't eat eggs and stuff. It doesn't change your total cholesterol numbers or HDL numbers, your LDL numbers and stuff doesn't change any of those numbers. And only 15 to 20% of the population is actually sensitive to dietary cholesterol. So when you have a doctor say, oh, you have to stop eating cholesterol, only about 20% of the population who get that talk really only need to, and I think if we need to talk about balancing our diet. So we've kind of done this swinging back and forth of eat fats, don't eat fats, eat butter, don't eat butter, eat eggs, don't eat eggs. And everyone's just like, oh, what do I do and stuff. And that's what we're here to help you with. Rachel, our dietitian in our office and stuff, she loves doing this as well and stuff. But everything's about moderation too, and looking at your labs and looking at your risk and stuff and looking at that whole picture and stuff too. And what kind of foods you like to eat too, I think is really important. Any comments about diet?
I think that was very comprehensive. And eggs have choline, which is really important for your liver health.
Mm-hmm.
So choline sources are really important. There's a lot of people that don't make choline in their, just because of their genetic makeup. So it's really important to have choline for our liver to function properly. Our liver has so many jobs, and one of them is to manage cholesterol and manage blood sugar between meals and detoxify and process toxins and drugs. And it's just such an important, it's my favorite organ.
Yes, liver and gallbladder, yes, we have to keep that happy and stuff. So supplements, everyone always sort of asks us, what sort of supplements? And I didn't write down any numbers because there's such a wide variety. There's different types and stuff. And that's what we like to help give you some guidance with. We don't want you just going on Amazon and going, I need this. And I've got, and I don't know if you do this, but I go to these talks and stuff. And there's one speaker I love to hear and stuff, Mark Houston. And he throws up this list of supplements. And I'm like, I need to buy that one and that one and that one. I keep that one for my dad and this one for my mom. And it's like, we need to, step back sometimes and realize that supplements are not everything. Our food first is really the most important thing, getting a good, healthy diet and stuff. Supplementation, I think and I'll show you a couple of supplements that I think are really key that we should have included as well. So magnesium improves tone. It relaxes us. It relaxes the heart so we don't get those funny little rhythms. It relaxes our stress hormones, improves insulin sensitivity. It supports over 300 enzyme reactions in your body. So magnesium's huge. Where do we get magnesium from? Fruits and veggies and stuff. Unfortunately, some days now, the way we grow some of our foods, we don't get a lot of magnesium-dense soil, so we don't always get a lot of magnesium into our fruits and vegetables. And we have to eat, everyone goes, oh, I eat my veggies. I'm like, you got to eat lots and lots and lots of them. So magnesium supplementation is something we use quite often.
We wrote a blog post about magnesium today.
Oh, there we go.
And everything is green, like wheatgrass. Everything is green because magnesium makes it green.
Yeah. Stuff. So, all right, so read the blog post and see if you get more information. CoQ10. CoQ10, as we get older, our bodies don't make as much ubiquinol, right? I always get ubiquinol. And so CoQ10 is something we sometimes need to augment into our diet a little bit more. It improves angina, congestive heart failure, funny little rhythms. It improves heart efficiency, and it has a blood pressure lowering effect. And when you hear about people who are on statin-type drugs, what those statin-type drugs do is they really tank your CoQ10. And people go, oh, my muscles ache. I'm tired all the time. One of the reasons why sometimes that CoQ10 level's been pushed down and stuff. So we really augment that with CoQ10. Carnitine, that helps those little mitochondria. Remember those little energy cells we said we need and stuff? That helps so much for those energy cells to work efficiently. This one I want you to remember. Vitamin K2 MK7. It's not vitamin K. Everyone always goes, oh, vitamin K, I can't go on that. I'm on Coumadin and stuff. Vitamin K2 MK7 has been proven to decrease plaque and calcification in the artery wall. It's been proven in studies and stuff. You don't see it as a supplement out there. It's always mixed with vitamin D and stuff. And the two are very synergistic to each other and stuff. But there has been a lot of information on vitamin K2. So we'll have to do a blog post on that, a blog post on that. And it also, what it does is it increases that elasticity in that artery walls and stuff. So we said we want that artery wall not to be stiff. We want it to be nice and flexible. We want to get rid of some of that plaque formation on the inside. D-ribose is really important to make energy. It helps with weakness, fatigue, shortness of breath and stuff. It improves heart function with patients who have congestive heart failure. Taurine helps to kind of lower some of our stress hormones, supports those kidneys. And we said, remember, the kidneys are where you make a lot of your hormones for blood pressure. Omega-3 fatty acid, remember this one? So, the doctors always, and there's data on it and stuff, is that after you've had a heart attack or you've had a stent or you've had a bypass, they put you on omega-3 fatty acids because it decreases the risk of you closing down or restenosing and stuff. So I always sort of think like your fish oils are sort of like the slipperiness, keeps everything nice and slippery and stuff. So it also decreases those funny rhythms as well. And it also can decrease plaque formation too. So omega-3. Now, fish, let's eat some good fish and stuff too. You don't always have to take the supplement, although if you don't like fish, there's a great option and stuff. Vitamin D, as we've kind of discussed, vitamin D has so many important functions in the body. One little interesting tidbit that I found, if your vitamin D level is less than 30, it starts to really affect your kidneys and your blood pressure is going to go up. So just by raising your vitamin D levels, you're going to naturally get your kidneys working better, and it'll start to bring that blood pressure down just by optimizing your vitamin D level. And we kind of like it between 50 and 80 and stuff. So garlic, remember this one. Garlic decreases that calcium formation and plaque formation in the artery walls as well too. You can take garlic supplements if you want, but I think, eating garlic and cooking with it is a great way to go and stuff. Arginine is a vasodilator. It's something that kind of opens up the vessels and stuff, increases the blood flow. Resveratrol, we said that's in wine and red grapes and stuff. It lowers that HSCRP, that inflammatory marker. And curcumin and stuff, curry, is got some anti-inflammatory benefits that we discussed. So a lot of this, just trying to get it incorporated through our diet, I think is really important.
And I would also say that we test a lot of supplement or nutrient levels in your body. So sometimes people will have a lot of supplements that they're taking. And it can be really helpful to streamline and reduce the number of capsules that people are taking by really seeing what is needed. And then the other piece is that sometimes you can buy, for example, fish oil, and you might not be buying the right kind of fish oil. Many of you are in the know and you understand that there's healthy form of bioavailable forms and non-bioavailable forms of fish oil. But there's a pharmaceutical brand, which you can get a prescription, it can be covered. And I was so excited when this came out. And I thought, oh, we now have a form of fish oil that can be covered. It's going to be less expensive for the patients. It was the non-bioavailable form. So anyone who's on prescription fish oil, where the doctor or the provider is writing a prescription, that's not actually bioavailable. And if it's a cheaper form of fish oil, unless it says triglyceride form, it's actually not bioavailable, and it's just a waste of money, and it's a waste of time, and it's also demoralizing because you want to see your triglyceride levels come down, you want to see your gut health improve, you want to see changes. And you can think, well, this isn't working, but that's just because it wasn't the right form. So that's also how we help.
Yeah.
I love the example of the K2 and K7 that you mentioned, Annmarie. So sometimes you just want to find out what it is that's right for you and the right form, and then you're good to go.
Yeah.
So you're using your resources wisely.
Yeah. And so kind of the take-home point: drink green tea, eat fish, or take a proper form of your fish oils. Eat garlic. And then your vitamin D with vitamin K2 is kind of, I think, a really important one to do. And you just have to read the labels on your vitamin D and stuff, and there is a lot more and more of them coming out nowadays. All right, exercise and stuff. So the big thing with exercise, and I'm not going to spend too much time on this, for cardiovascular health, it is getting up to 60 minutes, 4 to 6 times a week, but you can't just go for 60 minutes. You just got to start slow. Using electronics, I think, is really important, especially to self-motivate you initially. So whatever Apple Watches or Fitbits, whatever tool, your online apps on your phone and stuff, anything to get you sort of motivated and get going. The 10,000 steps thing, I think, is just great, just to get you going. Cardiovascular data, though, to really start changing things. Mark Houston has been doing a lot of research on doing high-intensity interval training. So really kind of doing these sort of boot camp type of things where you go really intense and then you come down, and really intense in a very short period of time has shown to really change some cardiovascular markers. But you can't have someone start with that and stuff. I think that's something that we start looking at down the road. Plus, my big thing is you have to like the exercise you're going to do. So I'm really a big proponent on purposeful movements. If you just like to go in your garden and just work in your garden, and that relaxes your stress hormones, which does relax, we can see how it impacts the whole heart and stuff. I'm all for it. If you like to walk, great, let's walk and stuff. But I just had to kind of give you the data on when we actually test a group of people, does it change some of these markers and stuff? And, the aerobic stuff and some resistance is important to do for cardiovascular health. The big key with this, and we talked about this in our meeting yesterday, sit less, move more. That is the big thing, is get off our behinds and stuff. They've now said that sitting is the new smoking, and sitting is going to cause more health risks than smoking ever has or ever will and stuff. So we got to get up and stand and move around frequently throughout our days. All right, and then sleep. Sleep is really important. So sleep, slows down aging, it lowers those stress hormones, increases the growth hormone and the sex hormones, which we said are really important for cardiovascular health. Kind of helps get rid of this belly fat here. And you can see someone who's had a sleep study that's done, and they said, oh, we've got sleep apnea. All of a sudden they wear this sleep apnea machine, and all of a sudden, what kind of diet did you go on? Oh, I just actually started breathing properly through the night. And the body goes, oh, we don't have to be so stressed and put on this body weight. We can lose some of this weight because you're not stressing. And I had a really, really funny patient a long time ago. And came in and he looked at me and goes, how was my sleep study? And I said, well, let me choke you 67 times during a minute. And he goes, what? I said, you stopped breathing 67 times, actually, not a minute, an hour. Sorry, 67 times in an hour. And he goes, what? I said, 67 times an hour, you stopped breathing. I said, what do you think your body's going to do? I said, would you do that to your pet? And he's like, no way and stuff. And I said, yeah. I said, that's what your body is like. It's under so much stress because it's like, breathe, stop, breathe, stop, breathe, stop and stuff. And, sure enough, he got on his CPAP machine, and within, a couple months and stuff, totally different person. Energy levels improved, weight came off and stuff. Cardiovascular markers changed dramatically and stuff too. And when he felt better during the day, he could make more of those changes with his diet and his exercise because he just wasn't exhausted all the time. So we said sleep is, really important for blood pressure. It lowers down blood pressure. We release hormones as we sleep and stuff that we can actually mark or kind of watch and stuff. And if you want to kind of at nighttime, your blood pressure should dip a little bit. If your blood pressure goes up at night when you're sleeping, that's actually kind of a scary risk and stuff for heart problems. And if it dips too much at nighttime, that's also a little bit of a concern. Blood pressure tends to be a little bit low in the morning, and then we want to see how quickly does it pop up. People who pop up really fast, we also get a little bit concerned with them, especially if they dip too low at the night and they pop up. Increased risk of strokes with that. So your blood pressure does fluctuate during the day, but good sleep is important to keep that blood pressure really stable. And so the list kind of goes on and stuff. The goal and stuff is 7 hours. That's the magic number, and it's been tested over and over and over and over again and stuff. So
However much you need. I need a little bit more than 7.
I need more than 7, yeah. The minimum, I think, we're looking at with our busy lives and stuff. So I'm going to make one comment, then I'm going to bring this over to you. So stress management, this is Dr. Tetlow's area. She loves talking about this, but one little statistic, owning a cat, you have a 30% decrease in cardiovascular death and stroke. So just wanted to let you know that. So, all right, I'll get you to.
So this is when I should put the pictures of our own cats up on the screen for you to see our kitties, and videos of us playing with the kitties. It's actually very relaxing to watch some of those. So, right, you go on YouTube, you can watch the animal and the pet videos. This is like really good stress reduction, the new stress reduction. So this is just a brief slide. This also gives, Annmarie has spent a lot of time preparing for this presentation. She's providing a lot of content and gives her a chance to catch her breath. And so a really important topic is stress management. Something that we now understand is stress is defined as we are someplace and we think we should be someplace else, right? So if you are in one place and you think you should be someplace else, there is no solving that issue. You are where you are, but you think you should be someplace else. So an example is traffic, right? I need to be arriving or I'm late. So that's a Brown University definition of what is stress. So this is stress management, which means how to manage, for example, manage stress triggers. So self-awareness refers to being aware of what is happening inside us and actually being present, because sometimes there is a autopilot, cascade, domino set of reactions that are happening inside us that go very quickly. Someone might say something or something outside of us occurs, but it's actually having a response inside of us. So it might be affecting our physical sensations, for example, what your stomach feels like, or we might catch our breath. It's affecting us physically. It can be affecting us emotionally, affecting us on every level. And it's actually our own internal thoughts, sensations, feelings that are the stress triggers. So it's not actually the outside event. It's our own internal response, which makes it a whole different ballgame when we think about how self-awareness can actually change our experience with the same stress triggers, continuing. So the same partner, the same job, the same body, but actually having the potential for a different experience, because you don't need the partner to change. You don't need to have a different physical moment. You actually can work with your own internal reactions, slowing things down and being aware of your physical sensations, feelings, and thoughts. And being aware of that level can actually stop that autopilot, cascade, domino set of experiences that it goes fast, especially if they're triggers that are deeply patterned in us. So self-awareness is really the first one that we'd like to talk about with stress management tools, because just being aware and just taking a moment to understand, like, oh, I've just been really affected by what might have just happened. And then deepening that awareness and actually working with it, and maybe taking the time later. Maybe we don't have time in the moment, but actually reflecting later about our unconscious patterns, our unconscious reactions, about how things outside us are affecting us, but actually working with the awareness piece. So mindfulness, has anyone experienced mindfulness? Right? Some of you are in the, yes, I have experienced mindfulness. So mindfulness is something that I first really heard about in residency. And I thought it was such a good idea that I took a training in mindfulness, just a regular training for patients, but it's also open to providers. So I was a resident physician. I took this class. I thought this was so great that I actually, as soon as the class was over, it was 8 weeks, once a week, I took it again right away. And then before I graduated from residency, I got trained to be a teacher in it. And I hadn't even, finished my training, and I didn't have a lot of extra time, and I am very, very happy that I used the little time that I had. So mindfulness is referring to that brief centering that we had, but the opportunity is to have a formal practice where we're training and cultivating our ability to be mindful, which is present and compassionate, sort of that open, unconditional attention of what's happening inside us. Simple but hard to practice. And so that when we're having those experiences that really trigger us during the day, we can actually practice that mindful state when we are as present as we can be, and accepting that we can't be fully present all the time. So formally mindful in a practice, but also informally mindful throughout the day. Guided imagery and visualization is something we touched on yesterday in our staff retreat. So actually seeing what we would like to have happen and actually feeling it, and that's a very, very important piece to actually imagining your health and working towards your health, having a good sense of what it is that I'm wanting, what does it look like, what does it feel like, what am I doing first thing in the morning, and actually spending time experiencing it in your mind's eye, which is a very powerful effect on our nervous system and our ability to manifest our health outcomes. Many different forms of meditation. These are just a few. Breathing techniques. Breathing, so we probably know, but pranayama is the Sanskrit word for breath practices. So pranayama is the science that goes with yoga. So we all know what yoga is. We know, like, we didn't used to know 20 years ago, but now we do. Right. So just quickly going through relaxation response, heart rate variability. Some of these are other, we can talk about these more in other classes as well. So they're very powerful stress management techniques we can talk about later or after the class.
So these are a really important part of our practice and what we like to incorporate in helping you achieve your optimal health and stuff. So summarizing and stuff, we want to focus on treatment and lifestyle interventions, based on your genetics, your nutrition, what kind of supplements you take, what type of exercise do you, weight management, lifestyle modifications, and medications if that is warranted and stuff. So it's based on your risk factors, which things that you want to involve and get incorporated with managing cardiovascular disease. So we kind of, slide into there. We want to kind of thank you. There's Lauren, Dr. Tetlow, myself, for coming out tonight. Lauren is doing our next talk next month on your gut health. So please take a flyer and come and meet Lauren next month. So we appreciate you coming out tonight. Thank you very much.
And I'll also just mention that we're trying a little bit of a different approach for next month's talk. We're doing case-based and a little bit more interactive. So we've also been working on our formats, and we would love your feedback about which type of format works best for you. Also, we got so excited about telling you things that I realized that we've had a little bit less time for question and answer. So maybe we can just take 1 or 2 questions and then finish it up, just because I know it's late and we'd like to let you go home and rest. So maybe we can just take 1 or 2 questions.
We'll just shut up.
Does anyone have a question? Looking at a 5 to 6 month average, it's a very high-powered, high-accurate result, so you wouldn't need to stop. And our last question.
When you have the molecules, large and small, we know we can change the numbers easily? Is that
Can you go from light